Hello, everyone. Good afternoon, and thank you for joining us and some of our advocacy partners to discuss NAMI Maryland's work on public policy. If you're here, it's likely you know who we are. The National Alliance on Mental Illness, NAMI, is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness, especially those with serious mental illness. Kicking us off virtually is Congressman Jamie Raskin, with a welcome and update from the Hill. Thank you.
Hey, everybody, it's Congressman Jamie Raskin from Maryland's beautiful 8th Congressional District, reaching out to all my friends from across the state at NAMI Maryland's Education Conference. And I'm delighted to be able to join you virtually and to emphasize the absolute importance of NAMI Maryland and NAMI Montgomery County's free support groups, programs, and educational offerings that really bolster our families in the communities that I serve and I know across the state. This afternoon is going to highlight NAMI and several of its advocacy partners' work on legislation to intervene early to help people with mental and emotional disorders and problems, to address racial health disparities, which continue to plague our society, and to increase access to life-saving services and more. One of NAMI's advocacy priorities, I know, last year was the 211 Maryland bill, and we got that done. And I want to thank you for that, for everything that you did to work on that. And of course, it was named after my beloved late son, Tommy Raskin. So thank you for everything you did to make that happen. It's a landmark legislative achievement in the state to have a program where people can sign up, so that we'll have state counselors calling people on a monthly or weekly basis or whenever they need help according to a plan that they set up. So your legislative advocacy was critical. And I know you came out for Advocacy Day always when I was a state senator. So thank you for always making the trek to Annapolis and now making the trek on Zoom to Annapolis. I know more than 200 people from NAMI attended virtually this year and played such a great role in passing the Tommy Bloom Raskin Act. So it means a lot to me. Our mental and emotional health agenda is critical. You know, if we were in a dictatorship or an authoritarian society, it wouldn't be important. Mental health is not important in a society like that, just like education is not important and literacy is not important. But in a democracy, mental health of everybody is essential for the positive and effective functioning of our society. So we need everybody operating at their best possible mental and emotional health. And we want to set up a series of policies and programs and institutions that uplift everybody's well-being. So thanks to Kate Fahrenholt, Executive Director, and Maura Moynihan-Cyphers, who is the Policy and Advocacy Consultant, the whole team at NAMI Maryland for all of the indispensable work that you do. I'm sending you my strong solidarity and love, and have a great conference, everybody.
Thank you, Congressman Raskin. So advocacy is by far one of the most important pieces of the work we do. Year-round and with a diverse group of stakeholders, NAMI Maryland advocates for effective prevention, diagnosis, treatment, support, research, and recovery that improves the quality of life for persons of all ages who are affected by mental illness. Together with our 11 local NAMI affiliates, we represent a statewide network of more than 53,000 families, individuals, community-based organizations, and service providers. Public policy impacts people with mental illness and their loved ones in many ways, from healthcare to housing to criminalization. NAMI Maryland advocates for high-quality, comprehensive mental health treatment, increased access to crisis, prevention, and recovery services. And one important thing to remember is that we don't do this alone. Every year, we're joined by hundreds, if not thousands, of individuals and family members to advocate on issues important to us. We also count on other advocacy organizations, legislative coalitions, and policymakers to help advance the cause. Today, we're so pleased to be joined by the CEO of 211 in Maryland, Quentin Askew, Delegate Charcution, a champion on mental health issues, Stephanie Clapper, health policy expert with the Mental Health Care for All Coalition, and Ellen Weber of the Legal Action Center. So without further ado, I'm going to hand it over to Maura Cyphers, our policy and advocacy person, for a bit of housekeeping, and then we'll get started. Thank you.
Thanks so much, Kate, and to everyone in this session for joining us for NAMI Maryland's 39th annual conference. Like Kate said, Maura Cyphers, policy and advocacy person for NAMI Maryland, and I'll be moderating this plenary session today with Kate. If you've got questions, please post them on the social wall to the far right-hand side of your screen. If there's time, we'll address the questions at the end of the presentation. There's a bit of a delay between Zoom and the conference platform, so be patient or put in questions as they come to mind so we can get them in the queue. The social wall is also the place for comments, concerns, or tech issues. We'll try to address as appropriate, and for tech issues, someone will reach out as soon as possible. Finally, when this workshop session closes, you will be prompted to fill out a brief survey. As a reminder, if you'd like to receive CEUs for this workshop, you must complete the survey in order to qualify. In the next hour or so, we'll cover 4 of the many big issues NAMI advocated for in Annapolis earlier in 2021. And really, we're grateful to have this strong panel of advocates because mental health advocacy has really become more important than ever. If you were in our earlier annual report session, you probably already heard some of these facts and figures, but I think they bear repeating again. 40% of Marylanders reported depression, anxiety symptoms in the last year, and many of them attributed to the ongoing pandemic. We know calls into crisis hotlines across the state and to NAMI's helpline have increased at a staggering rate. Marylanders at risk for suicide also, those numbers are on the rise again. Substance use related deaths on the rise after a slight drop prior to the pandemic. And then, of course, the increased likelihood of mental illness following a COVID-19 diagnosis. So we know that the mental health fallout and the long-term impacts from the pandemic are far from over. And NAMI's done an incredible job this conference, I think, covering them from impacts to providers, to consumers, and how we're going to recover together as a society. So today, we have invited our partners in policymaking to help us understand some of the impact and significance of the public policy that was enacted this past session. So we will start with Quentin Askew, the CEO of 211, to talk about the 211 legislation sponsored by Senator Craig Zucker and Delegate Bonnie Cullison. And Quentin, as you know, nationwide increases to mental health call and text centers have offered an early picture of how Americans are coping with the pandemic and the lasting impacts. And I think it's important to note that people who've never experienced mental illness prior to the past few years are really feeling some of the same symptoms. And so I think from NAMI Maryland's perspective, this new system, having some trained peer specialists and counselors who can listen to a person's story and provide that important validation, and then setting up that schedule for proactive check-ins and helping connect people to resources or organizations like NAMI is critically important. So I think if you could walk us through what and I know it only went live recently on July 1. So if there are any insights or updates to share how things are working, please do. But I think we'd love to hear a little bit more about this mental health check-in program from you.
Good afternoon, and thanks, Maura. We definitely appreciate it. And thank you, Kate, again, for giving us the opportunity and NAMI support with this legislation. And so we all have been affected, by this crisis that's currently going on. And I appreciate the opportunity to share a little bit about mental health check program. So I do have some slides to share with us to provide an update. And so 211 Maryland is the state's Health and Human Service referral line for the state. And so anyone across the state has access to 211, as we know. I just want to start with just a brief video.
When times get dark, we can't see the help that's all around us. Let 211 be your guiding light for mental health and other resources. Call 211 or visit 211.org.
And I think this, this brief video, sort of that shining light, is sort of an example of all the work that I think we all have done, is really just trying to be that light for individuals who have been affected by mental health. And so just a little bit about the Thomas Bloom Raskin Act. We are, again, grateful for the support with Delegate Kellison, Senator Zucker, Senator Augustine, who were original sponsors of this bill. And basically what the bill required 211 Maryland to do was establish an opt-in mental health services phone call program. And so it requires our call centers to make periodic calls to individuals who opted in, as well as connect those individuals to mental health services upon their request. So as Congressman Raskin mentioned earlier, the bill was in honor and named after his late son, Tommy Raskin, who was 25 years old, struggled with depression before taking his own life. And so this was an opportunity to honor, but as well as, ensure that this proactive mental health support services provides, again, that one-on-one connection with the warm, caring specialist, someone who's trained in suicide prevention and mental health support, just ensuring that, someone is available when it's needed. What the program really does, it three things. It really helps us to identify vulnerable groups. We've been, attempting to raise awareness, as many of the advocates here has been, really raising awareness about and education about suicide prevention and mental health support, removing the stigmas. And I'm sure we'll hear that often, but, really, again, trying to remove the stigma around seeking help for suicide prevention and mental health. It offers check-ins. And so, again, professionally trained, accredited local crisis centers provide these weekly, confidential, emotional support calls for as long as someone needs it. And so, it could be for a month, but it could be longer than that until the individual feels that they're empowered, to move on to other services. But also increasing help seeking. And so we want to, again, empower Marylanders to recognize, when they need support, they're able to reach out, but also on our end, really connecting them to the mental health services that they are seeking. So it's been really easy to connect to the program. We made it 3 easy steps. So someone can enroll in the initiative just really by texting health check to 211 MD1 to let us know that they have an interest in receiving a phone call. And so again, this proactive support is not, for someone who's just in crisis or, in immediate need. Is for, someone who may be feeling lonely, anxiety, depression, or stress, or just not feeling well. And so this particular program is to be able to provide that proactive, just check-in support for them. So you can enroll by texting health check, or you can register online, just simply 211md.org. So once someone enrolls, they'll connect with one of our specialists to get that first live call. And I think that's what's been one of the unique things about this program, is that it's an actual live person that they will be talking to. So it's not a robocall, but an actual live crisis specialist that's trained and certified to speak with them each day. And then they'll check in. And so they'll engage with this specialist on a weekly basis, again, for a month, for a week, for a year, if the need is. But until that individual feels like, they're okay, we'll continue to provide that ongoing follow-up services. It is, again, to mention, it's really easy to connect to the program, and we encourage all Marylanders to take advantage of this. Again, for this weekly check-in call, just really by texting health check to 211 MD1, sharing the information for those who might need that particular support. But again, being able to have someone to contact you on a weekly basis just to check in can make a big difference in someone's life. What we were missed to not mention as well is our 211 Press 1 crisis line. And so for anyone across the state who is in need of immediate attention and immediate connection, we also have available our 211 Press 1 crisis line. And so that's for someone who needs to speak to someone right away, where they can dial 211 and press 1, or visit the website at 1211md.org. But again, the health check program is available. It's up and running. It's active. It's available for anyone across the state. And we definitely encourage any and everyone to take advantage of and utilize this service to help support any of their mental health crisis supports, or just needs to have someone to check in and connect with them. With that, I will stop sharing and see you more.
Thank you. Thank you so much, Quentin. Really appreciate it. For the most part, we are going to save questions into the end, but we've got 1 minute, and then I know you've got another obligation and have to hop off. And so we've got a question from the crowd. Jocelyn asks, is the 211 PSA available in Spanish? I understand the services are, but it would be great to promote them in Spanish, given the high Latinx community impact by mental illness, whose greater barrier is language.
Yes, that's a great question. Yes, it is available in Spanish. All of our materials are available in Spanish. Our marketing toolkits are available in Spanish in multiple languages. And so definitely I would encourage anyone, if they just access our website at 211md.org/health check. So all the PSAs, all the marketing materials are in multiple languages that are available.
That's great. And I will make a point to help push that out too. So thank you so much for being with us today, Quentin. And, you know, I love the shining light messaging, and I think looks like you guys are well on your way. So I think let's move to another priority. We're going to talk with Stephanie Clapper next with the Maryland Healthcare for All Coalition. One of NAMI's primary policy priorities and objectives was to address racial health disparities, especially when it comes to mental illness and the treatment of mental illness. NAMI believes that people with mental illness deserve to be treated with respect and dignity within their community and be provided supports that enable them to be successful in managing their mental health. NAMI advocates for inclusion and community supports that help people focus on their health and fights against discriminatory policies. In underserved areas of the state, we know that racial health disparities make accessing mental health services nearly impossible. And that results in worse health outcomes for people with chronic conditions, substance use, and mental health disorders. And I think one other thing to know is that if someone with mental illness is seeing primarily a PCP, for example, they'll treat the mental illness or continue on that, but they might not be doing the somatic exams that they should be. And so if you have a mental illness or serious mental illness, your life expectancy, I think, is on average about 10 years shorter. And part of that is because of, you know, the failure to recognize and treat chronic disease. And so, of course, that is even more exacerbated in underserved areas or areas that have historically had less access to necessary healthcare supports and services. So I think that is why, in NAMI's view, the Maryland Health Equity Resource Act was such a major victory last session. So Stephanie, I'm gonna let you take it away. Tell us a little bit more about the bill, and then I know that there's pretty exciting immediate updates that you guys also have to share too.
Thank you so much, Moira and Kate, for having me and for all of NAMI's support for the Health Equity Resource Act. It made a big difference, and also for your support on prescription drug affordability, which is also a big health equity issue as well. So I want to talk today about some of the historical context for how we got here, and then what's going on right now and what resources are available. So I want to go back to 2012 to 2016 to start, because the idea for the Health Equity Resource Act came to us from then Delegate Eric Barron, Delegate Jazz Lewis, and Senator Antonio Hayes, who approached the Maryland Healthcare for All Coalition and said, you know, you guys have been around for a long time. We've actually been around since 1999. Our mission is quality, affordable healthcare for all Marylanders. And we want to work with you on getting up and running a program that worked really well for 4 years, but then it lost its funding. That program was called the Health Enterprise Zones Program, and it had $16 million over those 5 years. The money was used to provide grants and tax incentives and loan repayment options to 5 underserved communities with poor health outcomes, and it was really successful. It improved health outcomes, it reduced hospital admissions, it saved the state a lot of money, And the 5 communities where you can see here, they were in Annapolis, Caroline and Dorchester counties, Capitol Heights, Greater Lexington Park, and West Baltimore. And each of these communities did something different, a little bit different with the money, depending on the needs of their local community. So they all had some things in common, like expanding access to primary care, expanding access to community health workers. Prince George's really focused on opening a lot of new health clinics. Southern Maryland focused on mental health. They hired psychiatrists. They had a lot of work done with peer support, and they set up a good transportation so that people could get to all of their appointments. The Eastern Shore, they focused on mental health as well. They did school-based mental health programs. They opened up a new mental health clinic. They started a mobile crisis team in order to help divert crises away from hospitals and away from the incarceration system. And then I've got an example here of what they did in Annapolis with the Morris Blum housing. This is housing for elderly folks and people with disabilities, and at the hospital there opened up a clinic inside of the housing so that people both who lived there and people from the local community could take advantage of it. And there were higher proportions of Black and Latino patients compared with the general population. And I really love what they did here. They did things like they would have people from the community or from the housing, they'd go around and talk about the new clinic and what kinds of help was available there. They'd show up in the cafeteria at lunchtime, and they would do sort of cooking classes and blood pressure screenings and just kind of talking up what was available. And they really seem to treat people like, you know, like people. Like you might have someone who doesn't really know how to interface with the healthcare system. They might show up at their appointments the right time, but the wrong day, or the right day, but the wrong time. And in a traditional healthcare appointment, you know, you'd be turned away. But the whole perspective here was that, no, you help the person. You let them come in, you let them have their appointment. If they want to just come and hang out in the waiting room, you know, you say hi. If someone is having trouble and they're going to the hospital a lot, maybe you check in on them a bit more. What's going on there? They found out that one of the people was a little bit lonely and a little bit scared whenever something would happen. He would get a headache and he would go to the hospital and ask for a brain scan. He had back pain, and one of the folks from the clinic went to his room with him and helped him adjust his pillows and just checked in and saw how he was doing. And he felt way better, and he didn't have to go to the hospital because someone was there helping him feel better and feel cared for. So that particular health enterprise zone did really well and it saved a lot of money, but more importantly, it really helped improve people's health. And all 5 of the zones did. So I just wanted to give an example. So then we wanted to build on that progress. This past legislative session, we created a resolution that hundreds of organizations around the state signed on to help us build a coalition in order to get the funding to restart a program where communities could get this kind of financial support in order to improve health equity and reduce health inequities based on race, ethnicity, disability, and place of residence. We did a poll. We saw that Marylanders across the board wanted this program to go into effect. These are some of the hundreds of faith, business, labor, community, and healthcare organizations who helped us advocate for the legislation. We tried to drum up as much media attention as possible. So we got the county executives and our lead sponsors and Johns Hopkins and Mayor of Baltimore and the Attorney General all together in order to bring attention to the issue. We got a lot of good press coverage. All of that culminated in this past legislative session where we were successful. The Health Equity Resource Act passed, which was great because it only took one legislative session. We knew that this was important. A lot of times we have more time to build our coalitions. Sometimes our initiatives take several years, but health equity was really in the public view. We thought it's so important to take advantage of while people are thinking about this, and was able to go through. In less than a year, we were able to get it passed, and that's with NAMI's help. So what is this? So it's based on the Health Enterprise Zone program, but it's got so much more funding. You might remember the first program was $60 million over 5 years. This is $59 million over the next 5 years. So we're going to be able to do so much more in Maryland. And the way it works is it's broken up into 2 different time periods. So the first 2 years, there's $14 million for what they're calling the Pathways to Health Equity grants. And then after that, there's $45 million for the next 3 years for what they call Health Equity Resource Communities. And both of those programs are administered by the Community Health Resources Commission and assisted by an advisory committee. And the RFP for the Pathways program is available right now. So the Community Health Resources Commission, it's a commission that was created in 2005. It's within the Maryland Department of Health, but it's independent. It's got 11 members who are appointed by the governor. And in addition to these 2 programs, they also have other kinds of grants that they administer. And this is an exciting time because they just released the call for proposals last week. And they are hosting an FAQ session on this Tuesday. So any organizations that are interested in applying for this grant funding should definitely show up on Tuesday. And then they're going to be having regional forums across the state. And so what they're hoping is that different types of community-based organizations, hospitals, federally qualified health centers, clinics, education institutions will all come together at those meetings, and they will be putting together competitive proposals in order to get that grant funding and improve health equity in their communities. And the proposals are supposed to talk about how to address improving access to primary care, improving health outcomes, improving prevention services, and a few other health-focused goals, but also how to address social determinants of health, things that affect our health like housing and food and transportation, access to all these things where if you don't have them, your health it's going to take a toll on your health, and it's going to take a toll on your ability to get to healthcare services. Those forums are happening in October and November. They have the ones for Western Maryland and Baltimore City set up. They're still scheduling the ones for the Eastern Shore, Prince George's, and Montgomery counties in Southern Maryland. So again, if you're interested, I highly encourage you to go to those meetings. You can find all of that information at the Community Health Resources Commission webpage, where they've got both the call for proposals and the regional forum information. There's contact information there for the folks who are running the program. The proposals are due December 7th, so it's a tight timeline to get those in. And one more key date, this isn't directly related to the Health Equity Resource Act, but it is a health equity issue. There are new healthcare subsidies available for people to afford health coverage in Maryland. So if you are uninsured, November 1st, check out the Maryland Health Connection. There's new money, that's federal money for all age groups, and then specifically in Maryland for young adults. Young adults are the age group most likely to be uninsured. There are racial and ethnic disparities within that age group of who has access to health coverage. Tell everybody you know, check out the Maryland Health Connection November 1st and get health coverage. So that's everything for me. Thank you again, Moira and Kate, for everything NAMI is doing. It's so important.
Thank you, Stephanie, and congrats again. That was a huge legislative victory, and you're right, just in one session, like 60 million in funding is out of this world. So we really value the work that the Maryland Healthcare for All Coalition does. You guys are great advocates and I know can move mountains. So thanks again for being here today. And I think, you know, our audience is primarily individuals and family members, but we do have providers and other, you know, advocacy organizations on here. So I hope some of the folks in the audience today have an opportunity to take a look at that RFP and get involved. So next up, and just as a reminder for presenters and the audience, we are going to try and hold questions until the end because we've got two more excellent presenters we want to get to before we start on Q&A. So next up, we've got Crisis Services with Delegate Charcution. Crisis response is so important to moving us away from the criminalization of mental illness. 1 in 4 individuals with a serious mental illness will be arrested in their lives. NAMI Maryland advocates for help, not handcuffs, and we believe that mental health emergencies deserve a mental health response. Tragically, that's not always the case here in Maryland and across the country. This past session, Delegate Charcution successfully increased funding for our local crisis services by $15 million and led a very important policy conversation about the ways we can encourage a mental health response versus a law enforcement one. So let's talk about that. Delegate Charcution, you're up.
Great, thank you. Well, it's an absolute honor to be here, and I just want to start by, sort of reinforcing what has been said, but I think can't be said enough. First of all, thank you to Kate and to Maura for your extraordinary leadership, always, and especially in these kind of challenging last few years. I also want to thank everybody in the NAMI family, everyone who's watching, and all the advocates, and echo Congressman Raskin's comments about really how crucial your activism and your involvement and your participation is in the General Assembly. And I think I do like to make sure that we reinforce that and say that, as elected officials, how much it matters when you show up in our office, ideally and hopefully soon in person, but virtually, if not in person, and stay in touch with elected officials, because these are such crucial issues. And I think, we have the data that highlights how everybody is touched either personally or with a family or close friend by mental illness. But I think that, when there's so much going on in the General Assembly in any given session, your presence there is crucial to remind elected officials just how important this is, and how we need to get this right. We need to get our investments right. We need to get our policies right. And ultimately, it saves lives when we get it right, but it also leads to deeper relationships and better quality of lives for so many of our community members. So my focus, and what I'll talk about today, what we have been working on, has been at that crisis point, sort of at an acute crisis in the context of a mental illness. I do want to say that, of course, we recognize, even while we're working on sort of that acute crisis moment, we recognize that really strong investments in prevention, community-based mental health, in getting the broader mental health system functioning will keep people from getting to that point. And we also need to make sure that we get that crisis point right, because as we know, far too many people end up being criminalized, right? If you look at the data of who's locked up, so who's locked up either permanently or long-term in our state system, certainly in our county jails, huge percentages of folks in our county jails are suffering from mental illness. And then just also who's getting arrested, right? Who's spending a night or two in jail, all of which doubles down on the trauma and further harms both the individual who's suffering from mental illness as well as their family. In addition, the data on police killings is stark, and we really see a huge percentage of the police killings across the country come from police interactions with someone who has a mental health crisis. And so that's a situation where the police shouldn't be there at all, shouldn't be responding to a mental health crisis. And so the question becomes, how do we set up structures so we have mental health professionals responding to mental health crises? Because when we bring a law enforcement response to a mental health crisis, we're going to end up with either a criminal justice response in a jail or with a criminal conviction, or we're going to end up with death. And so that's really the focus. And I just want to share a few things before I get to the policy. I want to share a couple things. One is that I come at this actually very much from a personal perspective, that a family member of mine suffers from bipolar disorder and has many interactions with law enforcement over the years. And I've spent many days, standing in court asking for treatment instead of a criminal justice response. So I have that experience, but even with that experience, recognizing that because he's white, he has survived police interactions that had he been Black or Latino, he may not have. And so, so I have that personal experience, but also the broader context in my district. We had, just in the days, just in the last 3 years since I've been elected, we've had 2 people killed by police suffering from mental health crises. And so, so this year, we focused on how do we make mobile crisis units both better funded and more effective. And so there's really two pieces to that. The funding piece, I think people understand funding. We need funding to be, to have good responses. So there's one really important piece of what we did was extend and increase the funding for crisis response, and then require that a third of that funding go to mobile crisis units. So there's a number of really important things that funding can go for, but the mobile crisis units, we feel like really we need local government who's accessing this fund to double down on their mobile crisis unit programs. And so really wanting to direct more funding. Now we have some federal funding headed in that way and some additional state funding. So feeling more optimistic about funding for mobile crisis units, but it's something that we need to keep an eye on, and still not sufficiently funded. So we'll keep working on that as well. But the other really important thing that we did, and this is really where I want to focus, is talking about what makes a mobile crisis unit in the eyes of the state. So putting a statutory definition into a Maryland state law to make sure that our mobile crisis units are really responding and doing what it is that we believe they should be doing. So a couple of things that we did. One was that we established that mobile crisis units in general, and then specifically to get the grant, need to have a plan for cultural competency and language access. So that means that any given local government needs to look at who they are serving, who they need to be serving, and make sure that the folks in the response who are responding are doing so from a culturally competent place, as well as a language access. And I think that goes without saying, but I've had a number of conversations over the last several years, both with folks in one of the people who was killed in my district is Finhan Berhe, and he is Ethiopian. And I spoke to a lot of people in the Ethiopian immigrant community in my district after he was killed by police, really about how do we do a better job of making this cultural competency work. I also have had conversations with Indigenous leaders in the Baltimore area and a number of other groups about the way that the mental health system needs to kind of continue to be keeping an eye on and improving the cultural competency. So that's built into the mobile crisis units. We also require partnership with community groups and peer supports, specifically the ability to do referrals to peer supports and family and supports, not just for the individual who's suffering from mental illness, but also the rest of their family. We put into the bill requirements, into the law now, requirements that mobile crisis units have ongoing engagement with the community, that they do data analysis, including analyzing their effectiveness at keeping people from ending up in the criminal justice system and in emergency hospitalizations, and that data and the surveys and the ongoing feedback from the community be made public and transparent, and then there be opportunities for the community to further refine and provide feedback to the mobile crisis units. And so really making sure that it is a sort of community-based in a number of ways, both community-based in terms of the partnerships that are getting built so that the community can continue to be part of the healing, but also community-based in terms of input into the structures and the policies of the mobile crisis units. So there were two other pieces that, and it also, we also further defined the need to be sort of coordinating efforts with 211, which of course we just heard about the extraordinary efforts that 211 is doing now and on an ongoing basis. There were two issues that did not make it through in this legislative session, and the point that was made earlier about how phenomenal it was that the health equity bill came through in one session. I would reinforce that, and I'm grateful for all the work that was done on that. Sometimes some of the bigger efforts take a few years, and so we'll be back working on these next two issues and welcome your participation. So one was defining part of the definition of mobile crisis units being that they be designed to minimize interaction between law enforcement and someone who's suffering from mental illness. And so that didn't make it through, and I think that there is confusion both about the concept of minimizing, because that doesn't restrict that you could never ever have a police officer called, but also I think that we do see models where very effectively mental health professionals respond 99.9% of the time to these very same crises without police officer response, and everyone stays safe. Everyone stays safer than if police officers, than when police officers respond. And I think that what we saw this year is that we need to do some more education of my colleagues and just have that conversation more, really pointing to the models where even in very intense mental health crises can be responded to very effectively by mental health professionals. So and peer supports. And so so that'll be a piece of the bill that we'll be bringing back next year. And then we're also in conversation about this question about dispatch. And so while we want to there's 211, of course, there's 988, there's 311. So there's a number of different places where calls can go in. And but what we know is that most residents, when there's an emergency, they call 911. And so even while we're training people to make a different kind of a phone call, which we need to do, we need to train, our fellow community members to about mental illness and about effective ways to respond that keep everybody safe. But even while we're in the process of making that shift, we need to make sure that when people kind of do what is natural to do in a crisis, which is to call 911, that we have the ability to get a mobile crisis unit rather than a law enforcement response to that crisis. And so that's an area that I still need some more work. We didn't get that portion of the bill through. And so we're working with NAMI, with a number of other partners, and with folks who are working on the 988 work as well to really figure out what the right state level structure is that supports the right local level dispatch systems that will ensure that we get mental health professionals responding to mental health crises. And I'll wrap up there. Thank you very much.
Thank you so much. That was super informative and very in-depth. I know cultural competency has been a core value of NAMI Maryland's for years, and the work that you did around better defining what a mobile crisis unit is and what that response looks like is going to be part of, we've been talking about a transformational or transformative shift on how crisis services are delivered in Maryland. And so, peer inclusion, data gathering, all of those strategies for community involvement will help us build a more robust system that really reflects the community served. So, you can count on NAMI. We look forward to working with you on future bills, and thank you again for being here today. So without further ado, and last but not certainly least, we've got Ellen Weber. She's the Vice President of Health Initiatives with the Legal Action Center. Ellen also leads the Parity Coalition in Maryland. If you think that you or your loved one should have better access to healthcare, in particular treatment for mental illness, Ellen has been the architect of so many policies to fight for parity and ensure that mental illness is covered the same way other healthcare is. She has got toolkits for consumers and providers. She's helping scores of Marylanders understand their rights and advocate for them. So, we treasure the work that Ellen does. She's recently was a leading voice on the protection of telehealth expansions that we saw during the pandemic. So I think we'd love to hear a little bit more about your work on this, Ellen, because, it's the way I think all been talking about it, but telehealth has been an actual lifeline during the past couple of years. So thanks very much, and I will let you take it away.
Great. Thank you, Maura. And thank you, Kate, again, for inviting me to be here today. It's always such a pleasure and honor to speak with folks at NAMI. And again, the work that NAMI has done over the years as part of the Parity Coalition, obviously, and outside of that, has just been invaluable to us. And so want to just provide a little bit of background about the legislation and what led up to it, what is in the legislation, and talk about some actual next steps that are already underway, and also some opportunities for the public to help shape the future of telehealth. So next slide, please. And thanks, Tamara, for advancing my slides for me. Just to give you just another little bit of information about the Legal Action Center, we're a law and policy organization that fights discrimination, builds health equity, and restores opportunities for individuals with substance use disorders, criminal records, and HIV or AIDS. We have run the Parity at 10 campaign, which is the goal has been to achieve enforcement of the Mental Health Parity and Addiction Equity Act in both public and private insurance. And a new project that the center has been working on over the past year is now called the Medicare Addiction Parity Project. And our goal there is to do federal advocacy to address discriminatory coverage of substance use disorder treatment in Medicare. As Mara mentioned, in Maryland, we run the Maryland Parity Coalition. And again, the real goal of that coalition has been to end insurance discrimination against individuals with mental health and substance use disorders in both public and private insurance. And we do that work through organizing, advocacy, and education. Next slide, please. And so telehealth was one of the issues that we worked on incredibly actively over this last session. As Maura mentioned when we started this session, obviously COVID-19 has created just an unprecedented need for mental health and substance use disorder treatment. We have seen escalating need for treatment for anxiety and depression. There has been an overdose epidemic that has again disproportionately affected Black Marylanders. Prior to the pandemic, telehealth services were really used in a limited way. Audio-visual telehealth was allowed in Medicaid with some restrictions. And in private insurance, it was also allowed, but there was very minimal regulation. And so it was used in a very limited way. When the pandemic began, we all saw various public health emergency orders coming out of the U.S. Department of Health and Human Services, from Governor Hogan, from the Maryland Department of Health, that really allowed for the expansive and flexible use of telehealth. And as Maura mentioned, it really became the lifeline for safe, accessible, and more equitable care. And so what all of us experienced were access by delivering health services in our home. Providers were allowed to deliver those services also wherever they were located, often across state lines. Audio-only telehealth was permitted because we recognize that there is a digital divide in Maryland, and many individuals don't have access to the technology or the internet access, the broadband that is essential to do audio-visual. So audio-only was essential. And from the federal level, there were a lot of flexibilities around the way medications also were going to be prescribed, again, using telehealth. So with that, the Maryland Parity Coalition realized that we really needed to preserve these telehealth flexibilities in both in Medicaid in particular for mental health and substance use disorders post-public health emergency. I don't know that any of us ever expected 19, 20 months to be still in this public health emergency. We really didn't know when those emergency orders were going to be lifted, and we did not want to lose that continuum of services. And so what the Parity Coalition did was in July of 2020, we developed a set of recommendations to continue telehealth in Medicaid post-pandemic. And then what we did was we draft a bill to preserve the flexibilities in both Medicaid and private insurance on a permanent basis for mental health and substance use disorder care. Senator Augustine was the sponsor of the bill in the Senate, and Delegate Bagnall introduced that bill in the House. And then through the legislative process, that bill was folded into a larger telehealth bill called Preserve Telehealth Access Act of 2021. Senator Griffith sponsored that bill in the Senate, and Delegate Peña-Melnick sponsored that in the House. Next slide, please. So just to give you some quick information about what the key provisions of that was, the bill is retaining essentially the telehealth flexibilities that have been in place during the public health emergency for both private insurance and Medicaid for a 2-year period. So up until June 30th, 2023. And what those flexibilities are was, again, it protected audio-only telehealth in addition to audio-visual platforms. It allowed patients to get care in whatever location they wanted to get that care, as long as private. For providers, If they are providing services in the Medicaid program, they are also allowed to be delivering services in any location in which they want to deliver those services. For reimbursement, the important provision here is that audio-only telehealth, audio-visual telehealth, are reimbursed at the same rate as in-person care. And again, this was essential in order to be able to ensure that services would be delivered in all these formats to patients across the state, and the providers would be able to have a fair reimbursement rate in order to continue delivering those services. It also allows for remote patient monitoring, so the providers can monitor how patients are, how their care is coming along, doing that remotely. And this is very important with regard to individuals who are on medication regimens. Those kinds of regimens can be monitored remotely without the patient having to go into the office. One of the other provisions that was essential to the mental health and substance use disorder community was that of consumer choice. And what we mean by that is we wanted to ensure that health plans could not require a patient to get a telehealth service for mental health or substance use disorder in lieu of in-person service delivery. We all know that individuals have preferences for the way they get their care. Many love telehealth services. Many would prefer to go back to in-person services, and many want a hybrid. We wanted to be able to continue that because we knew how important that was. And so we were able to get that provision in the law with regard to individuals who have mental health and substance use needs. And then finally, a provision that again was very important to us is we want to ensure that the Parity Act applies to the delivery of telehealth services. And so we wanted to make sure, in particular with regard to the Medicaid program, which had some discrepancies between the delivery of mental health substance use services via telehealth and medical services, we wanted to eliminate those discriminatory standards. And so the last important feature of the bill, I mentioned early on that this bill is, these standards are in place for 2 years. What the General Assembly wanted to do was to study how telehealth services are now rolling out when we are in a less of a pandemic context, and then learn from that experience and then come back in the 2023 session and make permanent legislative standards for telehealth. So we'll have legislation coming back up in 2023, but we're going to be learning what has been successful over that period of time. Next slide, please. Just quickly summarizing where the benefits are of this. We know that telehealth has removed barriers to care. The transportation, childcare, work commitments that so often make it difficult to get care, telehealth services have really helped eliminate those barriers. It also provides people who want more privacy the ability to do their telehealth services or their therapy in their own homes. It has increased remote access, again, particularly with regard to audio only, because many, as we all know, there's a digital divide in our nation as well as our state. It protects consumer choice so that folks can get care in the manner that they and their practitioner think is most effective. And it supports the treatment community through reimbursement that is adequate and fair. And it permits for care delivery to continue while minimizing the rate of infection. Next slide, please. There's been some post-session activity that I just wanted to identify. Maryland Medicaid, much to our disappointment, implemented and imposed some restrictions, a few restrictions on Medicaid access, on patient access to mental health and substance use disorders under Medicaid. So right now, psychiatric rehabilitation programs cannot deliver group services via telehealth. And residential substance use disorder treatment programs cannot deliver more than 50% of services via telehealth. The General Assembly worked very hard to fight those restrictions with Maryland Medicaid and the Department of Health, but unfortunately those have been implemented. The other area that we're seeing some activity also on an ongoing basis is with the Maryland Insurance Administration. Because the Maryland Insurance Administration has an active process for revising our state's network adequacy regulations. These are the regulations that set certain standards to ensure that there are adequate mental health, substance use disorder, and other medical providers in carrier networks. One of the issues is, how do you use telehealth to count for the appointment wait time metric? And under current standards, telehealth can be counted as long as that service is appropriate and the member elects to use telehealth. In the current process, which is still in a deliberation phase, there has been a proposal that telehealth services must be clinically appropriate, available, and accessible, but they would remove that requirement that the member elects telehealth. We think that provision belongs in the regulations, and we're working hard as part of the coalition to get that changed when the final proposed rule comes out. It's an opportunity for community members to weigh in as well. Next slide, please. And then in terms of shaping the future telehealth services, again, we have a 2-year study period that's going on right now. The Maryland Healthcare Commission is leading that study. It has hired a contractor. And what that contractor is going to do is it's going to do 6 reports that will inform policy. And you can see on the slides what those areas of study will be. Impact on disparities. How is telehealth helping us resolve disparities in access to healthcare? Are there different uptake rates across communities or different populations? We all know from national data as well as state data that mental health, individuals who need mental health and substance use disorder care are using telehealth at a far greater rate than individuals who are using those services for somatic. So that is going to inform the future policy. We want to align with new models of care. We want to see whether telehealth can substitute for in-person services. And I think here, the use of audio-only telehealth as compared to audio-visual telehealth versus in-person services is going to be studied. And therefore, again, are these equivalent to in-person care? The last thing that's important to know is this is an opportunity for providers and consumers to be involved in this process. One of the key activities that the Maryland Healthcare Commission and its contractors are going to do is it's going to be gathering information through a provider survey, and it's going to be gathering information from consumers through focus groups. What the Parity Coalition did was to ensure that the providers of mental health and substance use services are clearly involved in this. We have worked with the Maryland Healthcare Commission. We have given additional names and organizations that can be used as resources for outreach on both the provider side and the consumer side. So NAMI Maryland is a prominent organization whose information has been given and who already works with the Maryland Healthcare Commission, but we want to keep these groups right on the top of their mind so that they're constantly reaching out to make sure that they really do gather the experience of individuals who have mental health and substance use disorders so that when the General Assembly comes back in 2023, they will understand the importance of these services for our community. With that, I appreciate the opportunity to share this information, and again, happy to answer any questions.
Thank you. Thanks so much, Ellen. We've got, I think, probably 6 or 8 minutes to answer a couple of questions before we wrap up today. So, you know, this has been a great discussion and plenary panel so far, and I think I'll grab a few of the questions that we've seen come through. One in particular, I wanted to respond, and any other presenters welcome to jump on too, but we had a question from Alita about how would a mobile crisis unit approach a person having a mental health crisis? Would they arrive in a plane, car, or van, or will it look like an ambulance with wording on the vehicles? And the answer is, especially in Maryland, that's going to vary county by county. So I know Baltimore County and Prince George's County, I think they both work with Affiliated Sante, and their crisis response model involves a law enforcement officer. And so it may be that they're coming out in a law enforcement vehicle. I don't know. I know what it looks like in Montgomery County, Maryland. They have county vehicles. They have jackets identifying them. If the provider-only mobile crisis team goes out, you know, there's usually a nurse, social worker, counselor, other mental health providers who can help de-escalate. And the purpose is to, you know, troubleshoot and triage on site, whether it's, you know, someone's home, most likely, or a person if they're unhoused in the community, occasionally a workplace or a storefront. If it's a mobile crisis unit dispatch and there's not law enforcement accompanying it, the likelihood of arrest drops incredibly. It's minuscule at that point. And very often there are hospital transfers and, if necessary, assistance with emergency petition processes. Part of the reason why this funding and defining what a mobile crisis unit looks like is so important is so that there are standards that guide, but there's also flexibility for communities. So like when we were talking about cultural competency, making sure that it's the right group of people going out and being able to troubleshoot and triage and treat. But I know even in the counties that have funding or walk-in centers, for the most part, it's still vast majority of law enforcement response. And so it's really figuring out how do we make that transition. And I think that's some of the important work that in sort of bits and pieces, everyone who spoke today is participating in.
Can I just add?
Go ahead.
Briefly to that, I think that, we want to have certain standards in place, best practices. And then I think you sort of said this, which is we actually put into the standards and the best practices community input into developing how the mobile crisis unit is going to be designed. And I think this question that you would want to be engaging around, a county mental health agency with the community would want to be talking about what would be the uniforms, the vehicles that would, kind of reduce, minimize, get rid of stigma, that would create a sense of safety and security for folks who are interacting. What is it that's important to the community, and how could that be incorporated? And so I think that, and that might look different in different communities in different parts of the state. And so I think that piece is an example of the kind of thing that you would want to be able to have the dialogue with a community about.
Thank you so much, Delegate Charcution. Stephanie, we have a question about attracting talents. How do you measure the quality of care minorities seek from a public health service versus private insured or minority folks who have Medicare? The person who's asking noticed a big difference between when they were insured versus uninsured. And so how are we attracting talented clinicians into racially and marginalized communities? And then how do we, and Ellen, if you want to jump into, how do we also then ensure that there's no stigma between private pay versus a public health service?
Thanks. Those are some big questions. The first thing I'd say is if you don't have insurance, things may have changed and you might be eligible for free or low cost health insurance now. So that's the first thing is check your options through Maryland Health Connection. Another thing is the funding through the Health Equity Resource Act is specifically looking at health disparities within communities, and communities have a lot of discretion on how they are looking to address that. So if there's a community where you're seeing these big discrepancies, I would encourage organizations there to put together a proposal. There's publicly available data that Maryland's Health Information Exchange is making available to everyone who wants to submit an application. Some of the data that you want might not even exist yet. And in that case, I would say that including how you would collect that kind of data would be really important in the grant proposal. In the original health enterprise zones, there were loan repayment options and tax incentives to attract healthcare practitioners to these underserved areas. And so that might be something that is going to happen in phase 2 of this program. It is, of course, it's a much larger question than we can address with any single piece of legislation, but it's really important, and I'm very glad that you brought that question up. Thanks, Moira.
Let's see. I think we're kind of coming to the end here. Let's see. I'm looking for anything we could answer in like 1 minute. I think we'll have to get back to the rest of the folks kind of in the chat. We've got resources and additional information to provide, but thank you again. I know Quentin had to leave, but it was great to have you, Stephanie and Ellen and Delegate Charcution, and to Congressman Raskin for kicking us all off. We really appreciate everyone being here today. don't forget to do the survey if you're seeking CEUs. And I think the next session starts in about 10 minutes, but I'm sure Danielle has alerted everyone in the chat. So thank you again. We're really grateful to all of our advocacy partners and look forward to continuing to work with you all.